Good evening, everyone, and welcome to Growing Pains, Bone Fractures in Children. My name is Joe Molony. I'm a physical therapy sports clinical specialist and manager of the Young Athlete Program here at HSS. In tonight's webinar, we are going to talk about orthopedic injuries in children. Our guests tonight are Dr. Peter Fabricant and Dr. Shevaun Doyle, both orthopedic surgeons who specialize in the treatment of pediatric and adolescent patients here at HSS. Glad to have everyone here, and thank you for joining us. For our viewers, after the discussion, we are going to have a Q&A session. So to start off, for Dr. Fabricant, let's start with the basics. What is a fracture? Are there different kinds of fractures, and how do they happen?
Yeah, so first off, thanks for hosting this, and thanks for having me. So a fracture is a broken bone. They're kind of one and the same. So the first thing I would say up front is that a fracture and a broken bone are the same thing. And there's really a multitude of different types of fractures. Really any bone can fracture, and it happens for kind of one of two reasons. Either the bone has seen like a load or a trauma that exceeds its structural capacity. So that would be like a traumatic fracture. Or a fracture can happen from like an abnormal bone, such as an osteoporosis that sees just normal day-to-day loads. That would be something like a stress fracture. Dr. Doyle's kind of a clinical expert on stress fractures in kids, so I'm going to leave most of that to her. But in the world of traumatic fractures, it really can be any bone in any location. It can be the shaft of the bone. It can be the growth plate, which is near the end of the bone. It can be into the joint or the articular surface, which is where the cartilage is. And then we typically discuss different features about the fracture. So is it really angulated or displaced or rotated? And that just describes kind of the position of the fracture. And then we also describe whether the fracture is a closed fracture, meaning there's no poke holes in the skin or anything like that, or is it an open fracture, which some people might colloquially call a compound fracture. That's when the trauma is kind of so bad that the bone is sticking through the skin. So that's just a couple of different varieties of fractures, but they essentially happen when either a normal bone is subjected to a very high load or stress or trauma, or that's an abnormal bone, or if a normal bone it's a normal bone, or if an abnormal bone, such as an osteoporotic bone, sees kind of repetitive overuse and can develop a stress fracture.
Great. Dr. Doyle, what activities put children at the most risk for fractures, and what considerations should you think about when choosing sports or activities?
Right, so most often in otherwise healthy children, depending on their ages, usually playground for the younger kids is a obstacle to they can cause trauma. So usually it's climbing structures or the swing or the slide where they can fall from a height. And generally, more so in children, they land head first versus adults. So the playground's kind of the hot spot for 0 to 6, 7-year-olds. Then as they get into organized sports, soccer is a big sport that causes quite a lot of injury, football and basketball. Europe, soccer is also really big, as well as skiing is sort of their hot area of causing fractures. So usually it's hard to prevent a lot of fractures, although there's been a lot of effort in order to help reduce the number of fractures. But namely, it's protective equipment, but that doesn't limit mobility too much. So skiers or snowboarders should wear wrist guards. Skateboarders should pad up knees, elbows. That can definitely cut back, and of course, helmets. So some protective equipment is helpful. Also, just making sure the playground structures have more of a rubberized or wood chip rather than concrete. There's still some in the city that have concrete. So those are things that kind of are safer for preventing injury, but it's almost inevitable that you're going to still have fractures to treat because children need to play in order to grow and socialize.
Sure, and I would think also rules of play would factor in just making sure that as adults we are ensuring that so that people aren't experiencing undue trauma.
Exactly.
And just to feed off one thing that Dr. Fabricant had mentioned, the stress fractures. Can you elaborate a little bit more on that type of fracture?
Yeah, so oftentimes stress fracture can happen in what might appear to be a normally healthy child that may be overusing a bone in such a way that the bone's not loading in any other way. So if they're suddenly starting up in cross country and a foot bone keeps getting pounded on, it's going to get an irregular force across it, which will eventually cause that part of the bone to stress. Sometimes we see kids with stress fractures because they have an underlying disorder, either of metabolism, they may have a hormonal imbalance, or they may be restricting dietary foods that are rich in calcium and vitamin D, and so their bones are actually weaker and they didn't know it. Some children have things like celiac disease where they don't absorb the appropriate nutrients and can have their bones weaken without them knowing. So they can be predisposed to stress fractures, or just an irregular amount of pounding in one place on a bone that hasn't been subjected to that can cause those stress fractures.
So it sounds like other than activities, there are other risk factors. Sounds like nutrition might be one of them.
Exactly. So nutrition, genetics, if they fractured at a younger age, if they have obesity, if they have more caffeine than they should, if they have, in the adolescent population, more risky behaviors such as smoking can increase your chance of stress fractures, alcohol use, all that kind of thing. Asthmatics that take steroids can sometimes be predisposed to stress fractures because of medicines, or children with seizures also take medication that can affect bone metabolism. They're subjected to stress fractures.
And when it comes to caffeine, what kind of a level, just so parents have a sense, would be concerning?
That's a good question, Joe, and I don't know the answer to that.
Okay.
But my guess is if you're drinking either a coffee drink or a Coke instead of a glass of milk, you're not helping yourself.
Gotcha. Thank you. So Dr. Fabricant, can fractures and injuries be prevented? Are there any preventive strategies out there?
Yeah, it's a good question. I think I'd kind of piggyback off of what Dr. Doyle said. You know, there's kind of two ways to decrease the risk of fractures. One is to strengthen the bone as much as you can, and that kind of goes into the stuff that she had mentioned with diet, kind of load-bearing exercise, avoiding, the vices that might decrease bone density. And then in addition to strengthening the bone, it would be dampening any sort of force that would be applied to that bone. And you can do that in a multitude of ways. So one way that Dr. Doyle mentioned would be protective equipment. So when you're playing sports, using the appropriate padding and protective equipment. Another, as you had mentioned, Joe, would be kind of the rules in younger kids. So there's some good data, epidemiologic data out of Canada to show that when they increased the age at which kids were allowed to have full body contact, it not only decreased the risk of concussion, but it decreased the risk of fractures in those younger kids who were still developing and didn't have the kind of neuromuscular control in order to check properly. And then in addition to kind of padding your body, another thing that Dr. Doyle mentioned was padding or kind of rubberizing the world, so to speak. So if you can go to a playground that has a rubberized floor or surface, that's gonna, if you fall, for instance, and you land on a rubberized surface, that's going to absorb a lot of the force that might otherwise be transferred to the tissues and the bones. I think the other thing would just be kind of, in addition to all that, trying to minimize the most risky behaviors. So I'm sure Dr. Doyle will attest, I think most of our upper extremity fractures that we see in school-age kids come from monkey bars, trampolines, bouncy castles, kind of things where you have lots of kids on a surface that might accelerate them towards each other at a high rate of speed. And so that's not to say that kids should never use monkey bars or never use trampolines, but perhaps ensuring that kids, if they're on a trampoline, they're kind of the only one on the trampoline. They're not kind of double bouncing with other kids, or it's not like a 7-year-old on a trampoline with a 15-year-old who's getting, launched off the trampoline. So those sorts of things, I I think would really decrease the risk of fractures in kids, both kind of the insufficiency stress fractures as well as the traumatic fractures.
Excellent. So when it comes, Dr. Doyle, when it comes to a fracture, is it always obvious, and what should parents be looking for as far as signs and symptoms?
Yes, so I would say one rule of thumb for parents, especially the younger children, since fractures happen in the upper extremity much more commonly than the lower extremity, even if they can move their fingers and it doesn't look that swollen, if your child cannot turn their forearm, so if you leave the elbow straight and they have trouble turning their forearm, that should be a reason to get an x-ray, because invariably they'll have a fracture. In terms of some fractures, we cannot always see on plain x-ray, but if, for example, sometimes a growth plate fracture will just be tender at the location of the growth plate, but because the growth plate is largely cartilage, it doesn't show up on an x-ray, but we assume that that's a fracture of the growth plate, so we won't always necessarily see it. And sometimes there are hairline fractures that we suspect because of the tenderness that somebody will have right on their bone. And 2 weeks, 3 weeks later, when we get an x-ray, we'll see signs of bone healing after the fact. That's actually something that, moving to the lower extremity, we commonly see. Toddlers go down a slide with a well-meaning adult that's trying to protect them, sliding in between the legs of their parent or caregiver, and their foot gets twisted, and then they can't walk. And a lot of times we won't see a little fracture in their shin bone until 3 weeks after we cast them, but they won't walk. So a lot of times we don't always see the fractures. So just those two things. Don't go down the slide with your child, catch them at the bottom, and if they can move their fingers and the school nurse says, no, it's not fractured, be suspicious if they can't rotate their arms.
Wonderful. Great advice. So, Dr. Fabricant, when should a parent bring their child to a doctor, and how should they know when to see a specialist?
Yeah, that's a great question. I think, like I mentioned before, and like we discussed before, there's such a wide array of fractures. It really can go anything from something that could be very easily confused for a bruise all the way up to kind of a really bad fracture that's quite obvious. And so certainly in the obvious cases, so if there's a very high energy injury, or the parent or the child notices a lot of swelling or deformity in a limb, kind of it's bent in a way it shouldn't be bent, or there was an injury that involves a lot of bruising and swelling, like the inability to move the fingers, and especially if there's like sensation differences. So and sometimes if you have a certain fracture of the elbow, you might have funny feeling in your fingertips, like it's asleep or pins and needles. Certainly that would be a reason to visit a doctor kind of more quickly, even if that means going to the ER or an urgent care. I think the more kind of subtle situations are, you know, lots of kids, they're playing sports, they're playing on playgrounds, kids are kind of falling all the time. I have a 2-year-old and she's kind of on the ground more than she's on her feet. And I think that most of the times there's not a fracture or anything to be worried about. I think kind of what Dr. Doyle was alluding to, which is when children either can't bear weight on a limb. So a 2-year-old who's normally running around all of a sudden will start crawling instead of walking, or won't really bear weight, or you can't do a specific movement. So for instance, you can flex and extend your wrist, but you can't rotate it like she had mentioned. Those are kind of more subtle indicators that you could be dealing with a fracture. And in any of those situations, I think it's certainly wise to seek some sort of medical evaluation. And depending on kind of how severe it seems, that can either be at an urgent care or with the child's pediatrician, or to come into a specialized center like we have at HSS to come be evaluated by our doctors. So I would say about half the time we're seeing kids who were sent over by their pediatrician or an urgent care or an ER, where the parent kind of brought the child in, you know, after hours or overnight because they were concerned. And another half the time, you know, they may have been injured playing soccer or on the playground a day prior, and something's not exactly right, and they bring them in. So we see kids that are kind of fresh off the field or the playground, and we see kids who are referred in by their pediatrician. But I would say that the general rule is if there's a limitation of motion, if there's an inability to bear weight, or certainly if there's any visible kind of deformity or inability to use, a limb, the hand, or to bear weight on the foot, that would certainly be a reason to seek an evaluation.
And
Joe, can I just say one thing?
yeah, absolutely. Go right ahead.
Dr. Fabricant and I get a lot of calls sometimes from parents over the weekend, like so-and-so just fell and it doesn't look like they can move their leg very well. I would just say that if you can get your child comfortable, and it's not a great time of night, if you can get your child comfortable and they don't really need a lot of pain medication, but if they're able to sense touch and nothing looks too deformed, it's probably reasonable to wait till the next day to be evaluated during normal hours. But of course, obviously, if the pain escalates, you'd want to bring them in. But a lot of times we get calls like, should we bring them in or not? And I'd say if you can make your child comfortable and nothing looks deformed and they're able to sense touch and there's no tingling, I think it's reasonable to wait till the next business day to come in.
Yeah, that's a great point, because I think that's a big challenge on those weekends, right? The Friday night, Saturday night, and even on Sunday, what do we do? And it sounds like if parents aren't sure, maybe initial step would be to contact their pediatrician.
Right.
Because they can, as Dr. Fabricant said, oftentimes you're receiving those referrals from the pediatrician as sort of a first stop, a gatekeeper. Except for obviously the more obvious cases. So on that line, Dr. Doyle, how is a fracture diagnosed?
Right, so most of the time we use a plain x-ray of the limb, depending on where the pain is localized. And we usually look at the whole limb. So if it's down at the wrist or in the middle of the forearm, we might get the whole forearm on an x-ray, usually with 2 or 3 different views to take a look. And then we look for a line. If it's a mild fracture, we actually look to see if the bones are displaced. So usually x-ray is the medium that we use initially. Sometimes with those stress fractures, like we mentioned earlier, we use 3D imaging, such as an MRI. We'll pick up sometimes a hairline fracture if it changes how we might manage it, or a CAT scan. But generally the workhorse is an x-ray.
And you had mentioned earlier that sometimes if it's at a growth plate, it may not show up on the x-ray. So if in your examination you're finding tenderness at the growth plate, but the x-ray looks okay, how is that managed?
Yeah, so we would just probably cast or splint the extremity and follow up. But sometimes if there's a little more displacement around a growth plate, sometimes CAT scan can be helpful. We don't really use it that often, but sometimes around the ankle we might, or if it's near a joint, we'll use a CAT scan. But usually with a growth plate injury, x-ray is the mainstay of monitoring. And then sometimes long after the fracture is healed, we'll have the child come back for another x-ray to make sure that the growth plate looks healthy and that the bones are growing as they should.
Great. So Dr. Fabricant, in general, talking about treatment, how are fractures treated and what's the role of physical therapy?
Yeah, that's a great question. I think, the general principles of fracture treatment in kids are aligning the bone to within acceptable alignment, understanding that some younger kids, you can accept a little bit of an angulation or a translation in the bone because as they grow, they'll remodel that. That's kind of a judgment call that we make, all the time as pediatric orthopedic surgeons. But getting the bone aligned, stabilizing it, and then allowing it to heal, and that's all really in the acute phase. And then certainly physical therapy is a component of that. Kind of more specifically, certain fractures are inherently stable, and so they're already well aligned, and you can treat those in a cast or in a brace for a short period of time. Some fractures require being set or manipulated into position and then fixed with either a cast, or sometimes we need to fix it with some sort of an implant like a wire or a screw or a plate in order to hold it in that position. And some fractures are kind of have lots of displacement or lots of angulation, and we need to actually make an incision in order to kind of remove any trapped tissue and realign it, and fix that with a plate and screws or pins or something like that. So there's really lots of different things on the menu as far as how to treat a fracture, but the general principles are to realign the bones, to hold them in a stable position and give it time to heal. Typically, every bone is different, and depending on kind of which area of the bone it is and what type of fracture it is and how young the patient is, it's a different amount of time for healing. But I'd say the quickest fractures can heal in somewhere in the 4 to 6 week range. But most fractures, even kind of in older kids, in areas of the bone that are slower to heal, most fractures will be pretty well consolidated and healed within 12 weeks or 3 months. And at the point where the bone is strong enough to start seeing a little bit of load is when we typically involve our physical therapy colleagues like Joe here. And the reason is because no matter what you do, whether that's treating it in a splint or a cast or with a surgery or something like that, there is a period of immobilization, and that does kind of, even though it promotes healing, cause stiffness and weakness, and that we need to kind of counteract with physical therapy. So I would kind of turn the question back on Joe and say, kind of, once we deliver you a patient with a bone that has, you know, some inherent stability to it and it's healing well, kind of what are your thoughts as far as progressing them back towards activities with physical therapy and things like that?
Sure. So I think, you know, the first thing we look at, and Dr. Doyle had mentioned as well, looking at more than just that specific area on the x-ray, because the joint above and below in particular is at risk for losing motion with the inflammation, swelling, et cetera, and immobilization. So, you know, the first thing we like to look at is, you know, how are the joints moving? And depending upon how well healed the fracture is, gives us the insight as far as how much we can, and certainly working with the physician as well, how much we can move and how aggressively we can work on motion. And I think one thing that's important for people to know for most treatment, physical therapy, but also for this, is it's not a painful process. It really shouldn't be a painful process. So range of motion would be the first step. Second, we want to build strength without, again, overloading the fracture. So muscles can atrophy pretty quickly. So we'll do what we can to work on strength and then do that in a progressive fashion and start to resume function and functional activities, because ultimately that's what we want to do, is return that individual back to being able to run, cut, jump, do weight-bearing exercises of the upper extremity, push-ups, etc. If it's somebody like a gymnast who has to do full impact, we certainly are going to work toward that as well. So that's basically the spectrum of how we manage it. There is a question that came up on the feed about, should I always bring my child to see a specialist for a fracture?
Yeah, I think I might jump in and answer that. I think that in kids, because pediatric fractures kind of are quite specialized, and like we had been talking about, you know, the kids we see range from literally hours old, from just being born all the way up through college. And those are obviously very different kind of physiological creatures. And we're dealing with different bones all over the body, different types of fractures, different amounts of remodeling capacity. And so I certainly think that with young patients, children, kids who are still growing, certainly seeing a specialist for a fracture is the right thing to do. And then that initial judgment call of how to treat that fracture is something that we do all day. And so I think we're kind of in the best position to do that. And that treatment may be, you know, look, you have a very mild fracture. It's a stable fracture. We're going to give you a removable brace and you're going to wear that for a month, and then you can go back to everything you want to do. Or it might go all the way up as high as saying you have a fracture around the growth plate that needs to be set and fixed with pins or screws or plate and screws. And that initial decision is an important one to make. So I think a specialist is the best person to make that decision. And depending on what that decision is, or that having that discussion and making that decision with the patient and the parents, depending on what that is, they may then follow up with their pediatrician, or they may then continue to follow up with the specialist. But I certainly think that having a specialist involved in helping guide through that first decision is really important. I don't know, Dr. Doyle, if you have anything to add.
No, I have, yeah, and I just want to tail on the physical therapist. The other thing is that we can guide the physical therapist, because sometimes there are fractures where we actually don't operate and still use sort of an old-fashioned cast, which can make the child lose balance. And if they have stairs to climb, therapy is invaluable initially with treatment, especially when a child gets a long cast either on their leg or their arm. And it's helpful to have the physical therapist teach them to navigate with crutches or a walker. So that's also something that's pretty helpful that Joe helps us out with quite a lot.
Yeah,
And I
that's
also
something.
think coming to a specialist, they can guide the patient to the therapist so that they're very safe once they go home with the fracture.
Yeah, that's a great point that I was thinking in terms of treatment as far as what we do for the fracture itself. But yes, for those who have a leg injury, learning to use crutches, walker is a big part of it, and we see those cases every day. So, Dr. Doyle, what's the healing process like, and how can caretakers and parents promote healing?
Right, so usually the first 2 to 3 days, there's quite a lot of swelling because the body is reacting to the injury. And so the blood kind of flows right to the fracture, and the early stages of healing are just sending a lot of white blood cells to turn into bone. And that process can cause a lot of swelling and discomfort. So obviously, we talk about rest, ice, elevation, and compression, but really, the elevation above the level of the heart for those first 3 days is critical to keep pain down, to keep swelling down, and to allow the healing to take place. Children are a little more forgiving than adults with the fracture mobility. So if there's a little bit of movement at the fracture, there's still a good chance for a child's bones to heal. But most of the time we're trying to keep it stable. So that's the point of doing a cast or an operation to stabilize with a plate or hardware. And that will enable our bodies to send blood cells that will ultimately turn into osteoblasts, which are the cells that make bone. And there are also osteoclasts that help the bone to remodel. So there's sort of a perfect balance between these white blood cells and our hormones, which allow healing to take place. And generally, within 3 weeks, things start to get pretty sticky and stable, and then over the next 3 weeks, things solidify. So the glue, if you will, if you say that the sort of a fracture is gluing back together with your own glue that you make from your bloodstream, the glue kind of hardens between, as Dr. Fabricant talked about, between 6 and 12 weeks.
So as a follow-up, when are fractures a cause for concern? And if the child has a fracture, should the parent be concerned about the bone health?
Yeah, so I guess I'll take that one, Peter. So usually, if it's a fall from a height where there's some energy behind it and there's some serious trauma, it's probably safe to say that it was a true accident. But if a child has an underlying illness, or again, like a malabsorption problem, or they're on some sort of medication or a restricted diet, we do kind of worry about the health of the bone even on a first fracture. But generally, if a child if they're younger than 9 and they've had 2 long bone fractures, we tend to get a little bit nosy about what their bone, how their bone markers are working, and we'll get a blood test to look for vitamin D and other hormones like thyroid hormone as well as parathyroid hormone, just to make sure that their bone metabolism is revved up appropriately. And we often find deficits of vitamin D. So that's something to keep in mind as well.
Sure. Dr. Fabricant, can fractures cause long-term complications? And in what cases would this happen?
Yeah, so many of the more mild fractures heal very routinely with minimal intervention and with a very, very small, if any, risk of complication. But certainly fractures that are sustained as a result of a high energy trauma, fractures that involve the growth plate, fractures that enter into the joint, so like in towards the cartilage surface. If those aren't properly treated, or even if they are properly treated, but there still can be a high risk of complications from the actual injury itself. If the growth plate is injured, it can cause a growth arrest or a partial arrest, where a bone might not grow as long as it would have otherwise, or it may grow at an angle one way or another. And that can cause limitations in motion, strength, and can cause some disability. If fractures go into the joint and and it injures the cartilage, that could cause an arthritis later in life. And as I mentioned, some of these things are kind of just the nature of some of these high energy fractures. And we're talking about, really bad falls from height, car accidents, children to unfortunately get, struck by a vehicle or a cyclist or something like that. That's why it is really important to make sure there's a specialist involved in the care of these children, and ensure that the bone is realigned perfectly and the growth plate is, protected and addressed. And if the fracture goes into the joint, that the cartilage is lined up perfectly and everything is fixed really well. That minimizes the risk of a complication later on from the fracture. Depending on the type of fracture, like I mentioned, it doesn't always eliminate it down to zero, but certainly it minimizes the risk of having those complications, such as, stiffness or weakness or disability or arthritis.
Yes, it sounds like, in this category, for pediatrics 21 and under, there are a lot, it's more complex, it sounds like, than perhaps in the adult. And again, pointing to the need to see a specialist.
Yeah, for sure. And I think that there are some things, like Dr. Doyle mentioned, about kids that make them easier to treat. So some of those things are, if, as long as you get the bone to heal nicely, that in kids, they tend to rebound more quickly with physical therapy, like with gains in strength and mobility. But some of the things are less well tolerated. So if you have some deformity in a limb as a young child, that might not be as well tolerated as, let's say an elderly patient who has a lower demand for high level sports activities. So certainly, pediatric orthopedic specialists are, really involved with taking care of pediatric fractures, just like our adult orthopedic trauma colleagues take care of very complex adult pattern fractures. And these sometimes overlap in the older kids, the high school and college kids, which is kind of the younger end of their spectrum and the older age of our spectrum. But certainly in the pediatric fractures, involving a specialist early is a good thing to do.
And as a general rule, for more of your typical fractures, it's safe to say that you would expect the child, the patient, to have a full recovery?
Absolutely, yeah. So our expectation in treating fractures, really any fracture, is that we can maximize the patient's ability to use that limb, that joint, that kind of bone, whatever is fractured, and it may take some time to get them to heal and to get them strengthened and balanced and able to run and jump and play sports again. But our expectation is that they would be able to do that with no limitations.
We have another question coming through. My 13-year-old sister has fractured her wrist twice and multiple fingers in gymnastics. Should she pick a new sport? And I think, this idea of sport and risk is a great topic. So interested in your thoughts.
Yeah, well, it's a good question. So every sport has its own risk profile. So we read a lot about concussions in football and stress fractures in performance sports like cheerleading and gymnastics and ballet and figure skating. In gymnastics, there are a lot of wrist injuries and finger injuries because it requires a lot of grip strength. And there's obviously even though there's a lot of protective equipment, there's a lot of kind of high velocity flying, tumbling, twisting, which does put kids at risk for fracture. So to answer the question of should she pick a new sport, I wouldn't necessarily tell someone they have to pick a new sport, but given the risk profile of gymnastics, that's a sport where fractures are not uncommon, as are kind of ligament injuries to the ankle and the knee and the shoulder and things like that. But picking a new sport might introduce, you know, a whole different array of injuries. And one thing that we kind of advocate, especially in our youngest patients, and even up to age 13, like this person in question, would be to cross-train and to be involved in multiple different sports that use different muscle groups, and to kind of avoid really early overtraining and early single sport specialization. So to answer the question, I don't know that I would totally ditch gymnastics, but perhaps maybe modify the risk factors with cross-training in other sports as well.
Don't you sports guys have a rule of thumb that the number of hours, it's kind of like a new push, that the number of hours of training should not exceed, or number of hours training per week should not exceed their age? Is that a true statement?
Yeah, Joe, do you want to take that one?
Sure.
I'll let you be
Yes.
the bad guy here.
Yes, and actually, there's an article. If for our viewers, the American Academy of Pediatrics has published a sports specialization guideline. Came out a few years ago. That's open to anyone to see, and it does address one of the questions that Dr. Doyle just posed there. That the thought is number of hours of training per week should not exceed the individual's age up to a maximum of 16. So if you're 12 years old, and it may relate back to the question that we just asked here, something that Dr. Fabricant mentioned, you know, if you're 13 years old, but you're training 20 hours a week, you may be having all these injuries because of overtraining, not necessarily the sport itself. So by that rule, also, you know, if you're 18 or 19 years old, you shouldn't be training more than 16 hours. So yeah, great question and great guideline. So Dr. Doyle, what can parents do to build and maintain healthy bones in their children?
Right. So diet, rest, and exercise are the key. So just with the diet, if your child has any lactose intolerance or just stop liking milk after a certain age, they really should have appropriate vitamin D on a daily basis so that calcium gets absorbed and is placed into their bone, because they're basically building bone until age 30. And so to optimize that, especially in the winter time in New York, we're above 36 latitude. So we want to make sure that everybody gets at least 600 international units of vitamin D3, and that's either by supplement or lots of milk or salmon. So that's key. Good nutrition, avoiding too much. So like milk should substitute for soda or Starbucks drinks a little bit. Also, just maintaining a healthy body weight is really important. It's key to be the right weight, not too light and not too heavy. When you're too light, oftentimes your bone accrual slows down, and if you're heavy, you increase the chances of forearm fractures just because of the impact. But also, a lot of times, adipose tissue kind of replaces muscle mass that helps to cushion your fall. In addition to nutrition, obviously behavior, like super high risk behavior, like going on an ATV 600 miles an hour is not really a safe thing to do. So just to be mindful of the risky behavior and making sure you have appropriate protective equipment.
Excellent. Okay, well, that covers the discussion portion. We'll now open up to audience questions for Q&A. So some people had already posed some, but now's the more formal time. So a question has come through. Is cross-training as simple as letting my child play on the playground, or should it be another sport? So probably another sport than their primary sport.
Yeah, that's a really good question. I think that there's data to show that it's important to get kids involved in multiple sports, but it's also really important to let kids have just free, unstructured play, right? So kind of the crazy thought of like just letting kids go to the park and like play with their friends and maybe develop their own game or just kind of play and not have any refs or coaches or adults around to kind of guide that play is really important. So I think I wouldn't say that cross training is as simple as that, but free play is certainly a really important part of not only just physical development and bone health, but kind of social and emotional development in kids, just kind of having them go out and play with their own rules, with their friends. So I think that free play, in addition to perhaps picking an additional sport or having the child pick an additional sport that's just different from the sport that they're playing. So for instance, if a child is playing baseball in the fall, they shouldn't be playing spring ball and summer ball, and then maybe their other sport is tennis where they're like hitting a ball overhead, right? So it's good to play different types of sports, so an upper extremity sport and a lower extremity dominant sport. That's a really good way to cross train, especially in kids who just want to be part of a team and they're very competitive. Getting them on teams where they're just kind of forced to play a different sport that's of a different kind of movement nature is a really good way to cross train. And then adding free play, like going to play on the playground or just kind of going to the park and playing with their friends.
Yeah, great point. And I think that free play for the younger children is really a big topic. And again, for anyone who goes to the American Academy of Pediatrics website to look at that sports specialization article, it speaks to a lot of what Dr. Fabricant just described. And trying to limit sports specialization early on and keep that diversification. And also, to another point, being rest. And so at least 1 to 2 days of rest per week and 3 non-consecutive months of rest throughout the year. So again, if you're playing an upper extremity sport year round and not taking breaks for your arm, as an example, and loading it throughout the year, that's going to put the person at more risk for just an overall injury. But as you increase the time in a particular sport, you increase the risk of something traumatic happening as well. Another question: when does a muscle sprain need care from a doctor?
Shevaun, you want to take that one?
Yeah, I would say if there's a lot of pain in the muscle with movement, sometimes we splint that to just rest it. So I would say if there's really a lot of pain with movement and it's not comfortable with a little over-the-counter medication, it's probably worth having us at least splint it.
Yeah, I agree. I think that, just like we had discussed, there's different types and severity of fractures. There's also different types and severity of muscle sprains. And certainly, kids are out, they're active, you get sprains and strains all the time. And if you kind of pull a hamstring or pull your groin or pull your calf, and it's kind of, they're able to bear weight and they're able to stretch and feel better, and maybe they're not feeling 100% the next day, but they start getting better and they're trending towards healing, even if it's over a couple days, that's totally fine. I think if either it's really bad, there's a lot of swelling, there's limping or inability to use the limb, it's just not getting better, those would all be reasons to see a physician or a musculoskeletal care provider.
And I think, another layer to that is how confident is the parent that the injury actually is a muscle strain. So I think that's another layer to it, because these things can be difficult to diagnose for any of us. Another question: after a period of time with no activity due to COVID, what's the best way to return to sport?
Yeah, this is a great question, and a lot of people have been asking this, and actually my partners and I have been seeing a lot of kids with kind of overuse injuries in our office recently, because now that some of the restrictions have lifted, kids have gone from kind of not doing much in the way of physical activity to kind of trying to get the most that they can out of a short season, and they'll kind of jump right into playing sports. I think the best way to get back to the sport, I mean, hindsight's 2020, would have been to kind of keep the strength and conditioning going during COVID. no matter how much you practice that, obviously there's going to be some decreased activity during COVID when we're all kind of on a lockdown. But I think that kind of easing back into sport, not overdoing it, and not, for an example would be like our baseball players, they kind of haven't been throwing, and then all of a sudden they go out and they want to start pitching in baseball games because the school said that they can have kind of a partial season, so they're going to get right after it. That always gives me a little pause in having kids go back to sport. I mean, Joe, what are your thoughts about kind of general strength and conditioning as a component of getting back to sports after a period of inactivity, whether it's a pandemic or it's just kind of the school recess or summer break?
Right. Yeah. That was one of my first thoughts, right? Because we see so much of this in all of our practices at the end of the summer as people are going back to sports. And so we've got a lot of that information already to know how this kind of scenario will play out because of everybody being inactive with COVID. So, to Dr. Fabricant's point, making sure that the return to play is gradual and progressive, not all of a sudden one day going out and playing the normal schedule. And then the second layer of, if you can, working on some simple strength and conditioning things even at home, with most people not having a lot of access to exercise equipment, body weight exercises such as squats, push-ups, calf raises, pull-ups, if you perhaps would have a spot to do that. Planks, absolutely. Even things for cardio and impact like jumping jacks, high knees in place. Again, I'm just thinking more, especially, for us in an urban environment where there's not a lot of space. I mean, certainly if you're in a more suburban or rural environment and your children can go outside and do some running around, or in any way start to play a condensed version of their sport. So, they play soccer and they can go out in the backyard and start to dribble and juggle and start to move. Anything that can help make that return gradual would really be the cornerstone. Another question, do you think it's too early to start some sports? My young son is eager to start lacrosse. So thinking it's too early to start some sports. I'm assuming that's coming out of same kind of a question, coming out of this time down with COVID.
Yeah, it's a really hard question to answer. I think, it depends a lot on the facilities that are available. It depends a lot on state and local regulations. It depends a lot on kind of disease incidence and prevalence in that location. So that's different in kind of Manhattan versus the outer boroughs. It's different from New York City versus upstate or Long Island or Connecticut or New Jersey or kind of other parts of the country. So it's really kind of something that a specific school district or kind of town should be considering, along with kind of medical professionals in that area and with parents and kind of stakeholders, kids, parents, people who are going to be playing. And certainly no matter what that decision is, it's important to have kind of active monitoring and surveillance for symptoms, making sure that, kids are, for instance, getting their temperature checked when they show up to the field, making sure that there are no symptoms of any upper respiratory tract type infections. But those kind of contact sports, soccer, football, lacrosse, basketball, they're all kind of high risk sports for that, for COVID. I think I was talking to some of my family members who are excited to get back active this winter with some skiing, because skiing is kind of a sport that's a little bit built for social distancing. You can ride the chairlift with your family. Most people are wearing some sort of a face cover on the mountain, and you kind of stay 6 feet apart from everyone else. So something like lacrosse is probably a higher risk sport, but it's kind of dependent on where it's taking place.
Dr. Doyle, any other thoughts on that?
Yeah, just when you ski, make sure you wear your pads.
Exactly. And yes, I think, and I've heard other patients, partial participation. I mean, I was to say for swimming, I know earlier in the year, had a patient who was going back to the swim team, and they were having one one swimmer per lane to start off. So I think we talk about lacrosse as an example. You know, if there's masks and social distancing and they're doing drills and keeping everybody apart, that's a possibility as well. So I think that's another factor. I think at the end of the day, if you're able to participate in the sport and follow the guidelines of mask wearing and social distancing in particular, you know, that makes a big difference. If they're going back completely, and as Dr. Fabricant said, making actual contact, then, you know, the risk profile of contracting something goes much higher. Oh, there's a follow-up here. Sorry, I should have been more clear. As in some sports, too risky for a young child and their bones muscle health. Okay, so we were talking about it regarding COVID, but the question
we have COVID on the brain, for sure.
Why would that be, right?
I think if they do stick skills and they're learning, you know, they wear their helmet and the ball doesn't come whipping at them, I think it's great for them to start at any age that they're interested and engaged, for sure.
Yeah, definitely. I think that every sport kind of has its highest risk, let's say, techniques or maneuvers. So in something like lacrosse or ice hockey or football, that would be kind of hitting, body checking, contact. And so kids, even really young kids, can pick up a lacrosse stick and kind of throw the ball with a parent or a friend. I think that's great. I think the key with the sports is, one, ensuring that the youngest kids aren't, you know, moving towards single sport specialization too young, and two, that that within any given sport, they're kind of, the rules are outlined such that it doesn't put them at undue risk. So the rules on kind of body checking at a really young age, when they still kind of have developing brains and developing neuromuscular coordination, making sure they're training on how to body check appropriately so that they kind of minimize risk to themselves and others.
Great, thank you. Okay, so just a quick review of the concepts that we've covered this evening. So a fracture is a disruption of bone, also called a broken bone. Those are the same terms. Fractures are not always obvious, but pain, swelling, and difficulty with bearing weight are signs of a fracture. And for the upper extremity, as Dr. Doyle mentioned, the inability to fully rotate the arm is another sign. Diagnosis often takes place with x-rays. Sometimes CAT scan will be used. Treatment ranges widely from immobilization in a brace or a cast to reduction for realignment and surgery, perhaps with hardware to stabilize the fracture, as well as physical therapy once healing begins to restore range of motion, strength, and function. Generally, healing takes about 8 to 12 weeks, and there are potential long-term complications such as deformity, stiffness, growth arrest, and disability, but for the most part, we're not going to see that. We would expect patients to have a full restoration of function. And from a prevention perspective, making sure that your child is getting vitamin D, has a healthy overall diet, performs weight-bearing exercises on a regular basis to build strong bones, and to be careful with high-risk activities we were talking about as a trampoline as an example. So that's all we have, the time we have for today. Thank you again for tuning in, and if you have any questions or would like to learn more about HSS, feel free to comment below or visit hss.edu. Thank you.
Thank you.